Next, Dr. Vigneshwar.
Good evening, one and all. I'll be talking about an unusual presentation of Hurthle cell carcinoma of the right thyroid lobe, whether it is Metachronous or Synchronous carcinoma. So thyroid cancers have historically been divided into 4 types: papillary, follicular, medullary, and anaplastic. Hurthle cell carcinoma of the thyroid gland is one of the lesser known thyroid cancer type. It used to be considered a variant of follicular thyroid cancer. However, in 2017, World Health Organization classified it as a distinct tumor type owing to its significant histopathological and molecular differences with follicular thyroid cancer. Hurthle cell carcinoma is now defined as a follicular thyroid cell derived cancer and not a variant of follicular cancer itself. A review of literature until recent time reveals there is a very low prevalence of a thyroid gland involvement in any laryngeal squamous cell carcinoma. Nonetheless, if it does occur, it does by direct extension. The vice versa also holds true. However, I present a case of right thyroid lobe Hurthle cell carcinoma with the left vocal cord squamous cell carcinoma. Hurthle cell carcinoma represents about 5% of all differentiated thyroid carcinomas. It is seen more frequently in females and generally diagnosed after the age of 40. Exposure to radiation to the head, neck, and chest, and family history of thyroid cancers presently known risk factor for thyroid cancers. Primary laryngeal and glottic cancers are uncommon, representing approximately 1% of all males and 0.3% of female cancer worldwide. Like other laryngeal cancers, smoking and alcohol abuse typically causes glottic cancers. So, synchronous tumors defined as a malignancies presenting within 6 months of the diagnosis of the index tumors, whereas the metachronous tumors are those presenting more than 6 months after the diagnosis of the index tumor. There are tumors presenting at the same time in the initial examination are classified as simultaneous tumors, and this term has been more recently introduced. So there was a 53-year-old male presented with hoarseness of voice since 4 months with the incidental finding of painless heart swelling measuring 5 into 5 cm in size, situated on the right side of the neck since 8 years, with no associated difficulty in swallowing or breathing. History of tobacco chewing for the last 20 years. On oral examinations were within normal limits. On ideal, there was an exophytic growth noticed on the left vocal cords, and thyroid function test was within normal limits. On 70-degree scopy, there was an exophytic growth along the entire length of the vocal cord, left. On X-ray neck epilateral, there was a large homogeneous radiopacity noted along the right paratracheal region, noted causing contralateral shift in the trachea. On CT neck plane and contrast, there was a large heterogeneously enhancing solid cystic lesion in the right paratracheal region, medially abutting the esophagus and trachea and laterally to carotid space with displacement of common carotid artery, likely exophytic nodule from right lobe of the thyroid gland. On USD guided FNAC, it was Bethesda's system of reporting category 3, which was follicular lesion of undetermined significance. So our patient was first taken for emulscopy excision of the left vocal cord growth, which was then sent for further histopathological reporting. Subsequently, after the relevant investigations for the right thyroid lobe swelling, he was further taken up for right thyroid lobectomy. Pre and post-op pictures. The key points noted intraoperatively are: during emulscopy, there was difficulty in visualizing the area to be operated as the larynx was pushed anteriorly. During right thyroid lobectomy, we encountered huge distended anterior jugular veins equal to the size of common carotid. The right thyroid lobe was huge in size and adherent to the underlying structures like the trachea and esophagus. Trachea was significantly displaced almost 4 cm to the left side. The mass was involving the right tracheal laryngeal nerve near the tracheoesophageal groove. Palpation of the nodes on both sides revealed no palpable metastasis. Histopathology showed well-differentiated squamous cell carcinoma of the left vocal cord and Hurthle cell carcinoma showing vascular and capsular invasions. So the final diagnosis were left vocal cord squamous cell carcinoma with Hurthle cell carcinoma of the right thyroid lobe, which is a metachronous carcinoma. So FNA cannot distinguish between a benign adenoma and malignant carcinoma for follicular and Hurthle cell tumors. It requires a thyroid lobectomy or thyroidectomy to perform a surgical pathological evaluation showing more than 75% of Hurthle cells, capsular invasion, vascular invasion, or infiltration of the thyroid gland to prove invasive cancer. Patients with suspicious nodules should have thyroid function checked with cervical node evaluation by ultrasound. Surgery is the mainstay of treatment of Hurthle cell carcinoma. Some patients may need CT or MRI evaluation for widespread disease depending on the presenting symptoms and laryngoscopic evaluation if present with local symptoms like dysphonia or dysphagia. PET-CT is useful in patients suspected of having metastatic diseases. Therefore, patients that are asymptomatic with well-differentiated tumors and indolent disease and no invasion, observation with regular follow-ups is an acceptable option in contrast to total thyroidectomy. If TSH is low, indicating a functional nodule, this can be confirmed by a radioiodine imaging scan. These functionally hyperthyroid or hot nodules are rarely cancerous and require management of hyperthyroidism or thyrotoxicosis. Glottic cancers, given the low incidence of nodal metastasis and the small, slow-growing nature of the primary lesion, early T1-2 glottic cancers can be managed very successfully with single modality treatment like transoral laser microsurgery and radiotherapy after biopsies. Conclusion. Multiple reports and case series have found thyroid lobectomy and total thyroidectomy to have similar outcomes in matched populations for non-invasive Hurthle cell tumors. Invasive cancers requires completion of total thyroidectomy, and radioactive iodine is commonly used in adjuvant settings for high-risk features like tumor size more than 2 cm, cervical lymph node metastasis, positive margins, microvascular invasions, or post-operative thyroglobulin levels are more than 1 nanogram per ml. It is estimated that only around 10% of the patients with Hurthle cell carcinoma lesions take up radioiodine. Hence, response to treatment with radioactive iodine are much lower in these patients when compared to other types of thyroid carcinomas. Since the majority of Hurthle cell carcinomas are non-iodine avid, a negative post-operative radioactive iodine scan may not necessarily rule out distant diseases, and it is recommended in patients with high-risk features to undergo FTGPT. For patients with de novo residual cervical disease, neck dissection can be considered if feasible. If surgical resection is not possible or contraindicated, then external beam radiation therapy or intense modulated radiation therapy can be considered. If the patient's tumor is not amenable to radioactive iodine, systemic therapy with tyrosine kinase inhibitors like lenvatinib or sorafenib is considered. Patients with multiple malignant primary tumors are often described based on the chronology of presentation as simultaneous synchronous or metachronous. In this case, it is Metachronous. These are my references. Thank you.
I would request Dr. Amit Pradhan sir to hand over the certificate to Dr. Vigneshwar.